Let's talk universal health coverage, right? And the conversation has been there for quite a number of years now on what needs to happen to see UHC working. So we know the pilot projects that were done in the 4 counties. They say that there was a report. We've never seen the report, but we know what we heard from the people who enjoyed that and the difference between what was being piloted to what is ideal going to be rolled out. We've had a conversation with the NHIF CEO a number of times before, but today we've decided, you know what, this having you out there talking to us is not working for us. So come in here and talk to us from here. So Dr. Peter Kamunyo, the CEO of the NHIF, is with us in the studio. Good morning, Dr. Harry.
Good morning. Thank you for having me on the show. Such a pleasure to be here live.
Finally, it's good to have you. Welcome to the hot seats.
Literally.
This one is not as hot as what you sit on when you're right there in your office.
On a daily basis.
Yeah. Yours is usually about, 560 degrees Celsius. This one is about 5,060 degrees Celsius. It's not as hot. So, the conversation about UHC has gotten to a point where in Parliament we've seen the National Assembly passing the NHIF Amendment Bill 2021, and now that has gone to the Senate. And we've been looking at the conversations and reporting around this and what the bill contains and what the bill is proposing to do. And that's what we want to understand today. Yeah. Among very many things is the employers are now also going to be paying for their staff, NHIF. Hey, so what happens? Are employers still going to be taking for you your other cover for medical? Other conversations that have happened. So is NHIF going to cover more people? Is it going to be mandatory for everybody to have NHIF? All these questions. A couple of weeks back, we had with us in the studio the CAS for Health, Dr. Mercy Mwangangi, who has told us many times that she has actually worked in the background on universal health coverage a number of times. And I just want to play that clip of what she was talking about, the idea behind NHIF being revamped, and also the UHC and universal aspect of UHC. This is what she said.
One of the principles of setting up what you call a social health insurance fund, which is what many countries have done and done successfully, is that you have to have everyone in the pot. We're talking about UHC. The U in UHC is universality. Universality means everyone in the country. And that's the first step that this bill has done in ensuring that we legislate. It should be mandatory. Now I hear the noise. The second thing is, okay, if it's mandatory and we have close to 36% of Kenyans who are living below, the famous $1.50, how are those guys going to get in? And I can tell you now, there's firm commitment that government will ensure it pays that 6,000 Kenyan shillings for that group. So everyone else then, therefore, has been determined to have ability to be able to pay into NHIF, and there will be mechanisms
so that's what she
to ensure
said.
we are all in.
Now explain this to us. Is it true that this bill and what the idea behind what you've been working on is to have everybody contributing to NHIF?
Thank you, Eric. Kas Mwangangi couldn't have been more correct. And I always like starting with definitions, and you do that on the show quite a lot. So what does universal health coverage actually mean? It just means that everyone has access to quality healthcare, promotive, preventive, that they need, and while they're accessing those services, they do not suffer financial hardship. That is the WHO definition. So 1, it means everybody. 2, the care that you need. 3, that you do not suffer financial hardship. So that is where something else comes in. It doesn't mean that it is free. It doesn't mean that it is the same for everybody, but it means that everyone in that jurisdiction, in that area, has access without suffering financial hardship. Now, when we come to Kenya, and I would like to dovetail from where Kas Mwangangi had talked about, that for us to ensure that every Kenyan has that access, what needs to happen? You know that from the pilot, and you keep referencing that, the pilot which was done in 2018 was done on a model called input financing model. An input financing model is where you have the commodities available at the hospital, the infrastructure is there, the human resources there, and then registered people access those services for free. That was actually opportune for the first phase of the journey towards UHC, whereby is to ensure that the supply side is present. Now, that model, over time, you find that it is not sustainable because you still have to keep financing it. And that is why now, as we are going to the third and fourth phase of scaling up universal health coverage, we are using a model called output financing or insurance model. But in other words, it's a risk transfer. So we're transferring the risk from that out-of-pocket expenditure. We're transferring the risk from government funding of the hospitals. We're transferring the risk to an insurer. And you know the principles of insurance is pooling of risks. So you need to have everybody together contributing something little. And out of everybody contributing something little, there are those who will consume those services. Now, the spirit that we have now for scaling up for universal health coverage is that everyone must contribute. Now, if we go to everyone must contribute, how do you ensure that? We know even our natural behavior, like even motor vehicles. If it was not mandatory to insure our vehicles, I doubt many of us would be insuring them. So let's say now we have made it mandatory for everyone. Then there are those people who, whether you like it or not, they cannot afford. These are the people we describe as indigents or who cannot afford basic necessities of life, including healthcare. And you had the percentage from Kasmwangangi, but according to the last Kenya National Bureau of Statistics census, we've identified 5.1 million households who are indigent in this country. So to get to UHC is that we obligate everyone to pay, and then those who cannot pay to be identified and supported. And as you can see, the government of Kenya, with Ministry of Health and Department of Social Protection, we've already started by the government sponsoring the first 20% or 1 million households. And the plan is to scale that up to ensure that we get to the 5.1 million households and to have a tool to identify them year in, year out, so that we continuously identify these people and support them. Because you know, poverty or indigence, your status can vary at any point in time.
So then, even as you look at this, so we're looking at the challenges that were clearly evident with getting everybody in this pool, even before the suggestion of the UHC. That was a challenge, and I don't think we can run away from that.
Yes.
So looking at the fact that if UHC is to succeed, everybody has to be involved.
Correct.
So do you see then making this contribution mandatory as a way to reach that end?
Absolutely spot on. The contribution has to be made mandatory for us to be able to succeed. And by making it mandatory is also because, as you've seen, normal human behavior and even the challenges that we're having right now. Because right now, NHIF has been open to voluntary contributors since 1972 with all those benefits. But do people contribute? No, they do not. When do they come rushing to NHIF? When there is a need. And that is what has created also the problem that we are having right now, which we call adverse selection, whereby you see the pool of people who are contributing right now are those who are going to get major surgery, those who are consistently getting dialysis, etc. But that is something that we celebrate. And as we celebrate that and we want to scale that up, we have to make sure that NHIF also still remains sustainable. And that is how we ensure that everybody contributes. And the contribution of 17 shillings a day equivalent for a whole family, that is principal member, spouse, and up to N number of children would be covered for that whole raft of benefits. So I think it is, as a means of social protection, it is one of those things. And it's a commitment of His Excellency, the President, to ensure that we actually attain universal health coverage by next year, 2022.
17 shillings.
17 shillings.
Multiply by 30.
17 shillings per day. Multiply that by 30. You're looking around about 510 shillings per month. And that would essentially cover you as a principal member, your spouse, partner, and children, like you said.
Yes.
It looks like something that's attainable. It looks like something that's achievable.
Yes.
Now, having removed the number of people who are indigent, as you've said,
Yes.
so essentially you're saying that everybody else, apart from those who have been identified, can actually afford to do this, right?
Correct.
Now, if you have that basic structure set up where you have the funds that you need, right? Everybody's contributing on a regular basis. You don't have these dormant accounts, like also another thing that has been the bane of this negative existence previously. Delivering this, NHIF has been given this huge responsibility as being the vehicle that would deliver UHC. That means that there's so many other things that you need to look at around the country. Infrastructure.
Yep.
Facilities. I mean, we know that Nairobi Metropolitan Service is doing a fantastic job in terms of putting up facilities in Nairobi, but there's the whole country to look at. Yes. Is the infrastructure available then upon which this vehicle can deliver UHC? Is it available to the point of satisfaction? Because you can have the service, but then you don't have the facility or the infrastructure.
Yeah, that's a great question. And right now, every Kenyan can access a facility, right? The challenge is that by accessing those services, it leads to about 1 million Kenyans becoming impoverished because you cannot sustain that out-of-pocket expenditure.
Yeah.
Now, looking at the infrastructure of NHIF, NHIF has been in existence for 55 years now. And currently, if you look at the spread, we have about 156 service centers spread across the country. 70 fully fledged branches, about 36 satellite clinics, and also at Huduma centers. Our provider network currently is 7,666, spread across the whole country. About 75% of them being government facilities, public facilities. And then the rest, a mix of private and faith-based. So the infrastructure does exist, and we're looking at ensuring that that actually is improved. We have to thank also devolution, because devolution has actually assisted also a lot of the public facilities to improve. You've seen what is happening with the level 4s, especially the level 5s. The services have really greatly improved. But also the investment by Ministry of Health at the level 2 and 3. And we're also looking at enhancement of the level 1 facility, level 1, which is at the community-based level. So the whole continuum of care is there and existing. And why is it that using, for example, NHIF as an insurance model is a sustainable one? Is because you and I become members, active members, and we go and access services at a facility. Then NHIF reimburses that facility. So what we create is a sustainable loop. And that is why these models, if you look at best practice also across in other countries, is a model that works. So the thing is to ensure, because this is risk-based, that also NHIF remains sustainable. And to remain sustainable, the first thing that happened, if you recall in the HEFREP, the Health Financing Experts Panel, who advised on a raft of reforms to ensure that NHIF is robust, sustainable, and transforms to become a strategic purchaser of health services, not passive. So that way we can be sustainable. And there were four big buckets of reforms. One of them was legislation, which is what we are now, hopefully we'll see it through. Then another one was digital transformation, because to handle that volume, now back also to your question, you require digitalization of our systems and processes to ensure that we're able to, number one, monitor and evaluate, be able to react in good time. And you can see the progress that we have been able to manage in the last couple of months with the biometric registration. We actually went fully e-claim from 11th of July this year, and our self-care platforms, and I hope that you download our app so that you can be able to interact. And then the other third bucket is on benefits. Working together with the Ministry of Health, we've been working towards improving the benefit package to the harmonized one that will ensure that everyone has services. Right now, we're using the super cover, which we have just proposed improvement on it to be able to attend to people's needs. And then, so with all this raft of benefits, we are ensuring that NHIF continues to be there,
To be sustainable.
and leave no one behind.
You know, one of the things that you've mentioned a number of times is sustainability of NHIF. But then if you look at the care-seeking behavior of many Kenyans, you will go to hospital for curative care. At that point when you're already sick.
Yes.
The investment, like you've said, in the counties at the national level is on the level 3, 4, 5s, but not much on the community level, which is where the promotive and preventive would be. Isn't that already a risk for NHIF? Because now we are talking about NHIF, people contributing, but people also having a higher risk of using the service because they'll fall sick, instead of the promotive side of things.
Indeed, when we're looking at UHC, and even as we started, you have to look at the whole, it's a whole systems thinking, starting from preventive and promotive, and then to curative and even rehabilitative. Now, each component, the approach is a bit different. For example, as you mentioned, the preventive, promotive would be at primary care level. And there is a major investment going on at primary care level right now, spearheaded by the Ministry of Health, the county governments, to ensure that people are able to access that service. NHIF, in scaling up, is addressing the issues mostly of risk at point of access of services. So it is at a service provider level, because we reimburse services at that point. And indeed, we also still do a bit of preventive, because we offer vaccines. There's also issues to do with family planning. And all these are preventive issues. So, but when you understand the concept of insurance, whereby it's a risk that once you expose, then you pay for it. So it becomes very difficult to pay for a preventive where you have a pool of funds which are finite. They're not infinite.
I'm actually not even talking, I'm looking at it from holistically as government.
Yes.
So there's NHIF, which will be covering the reimbursements at the health facility.
Correct.
But then the government should be focusing a lot more on the promotive preventive. And you're saying there's a lot of work being done. Where, Dr.
Oh,
On level 1 on community. Which community?
but by the way, if you look at the counties, there's a lot of investment going on on community health volunteers and community health workers. Even in terms of our promotions, we actually sometimes engage the facilities, actually even in Nairobi Metropolitan Services right now. And you saw the other day when His Excellency launched a couple of level 3 hospitals in Nairobi Metropolitan. And right now we are on... we are going around scaling up, identifying the indigents who have been identified by the communities, by the county, to register them on NHIF. And the teams that we're actually using the community health volunteers and the community health workers at the ground level to assist that. So they are indeed playing a role in that. And you know also what as government also worked on, the user fees forgone at the level 2s, and also the investment, because if user fees forgone, it means that there's an investment in terms of commodities being sent there, etc. So indeed, it is a continuum, and we need, as you said, we look at it as a whole systems approach.
What you say is true. We had the Chief Officer of Health in the NMS sitting exactly where you're sitting,
Right.
and he explained to us this same principle. What I'd like to know is, for this 510 shillings, what do I get?
And actually, it's 500 shillings. So it should be 16 point something. It was rounded off to 17. And for 500 shillings, this is what you get. You get outpatient services. You get inpatient services. In addition to that, we have special packages, and these have been developed to ensure that we meet the needs of our people. We have a surgical package, both from minor surgery to major and specialized surgery. We have renal care. So this is where you have dialysis, and this is one of the most popular and helping very, very many lives. Actually, at the moment, it actually accounts for 7% of our total expenditure just on dialysis. We have a renal transplant. So even up to transplant, it's being done. We have other packages like rehabilitative package for drug, let's say like drug abuse. We have packages that oncology, another very highly utilized package.
Yeah.
All the way from diagnostic to treatment, even PET scans are covered, and chemotherapy. So all these packages are designed to meet the needs that are growing of people. Yeah.
What's the ceiling?
The ceiling.
Because package good, how much am I allowed to spend? How sick am I allowed to get?
Up to how much?
Great question. Our approach to the packages, and this goes to being able to offer services that are adequate to the people, is we do package fees. So, for example, if it's an oncology package, so for oncology, you'd get paid up to 6 sessions, up to about 100. And this has been in consultation with the specialists. So you'd find that if you're going for second line chemotherapy, for example, right now it's 100,000 per session, up to 6 sessions. That would take care of that. So we look at...
What if you require more?
Now, if you require more, if it is off, then it will have to go up to the limit. But what the packages have taken care of is majority of the occurrences. So if 1 out of a million in a month requires more than that, they would have to top up the extra. Because...
What I'm actually asking,
yes,
I understand that, is that is 500.
Yes.
What if I want to pay 1,000? What if I want to pay 2,000? What if I want to pay 3,000? What if I want to pay 5,000?
Great. Then, as we want to work also with private sector, is I would advise you, in addition to the NHIF cover, you can purchase a private insurance to augment what you're doing. Because our aim is to ensure that every Kenyan, from the indigent, has access.
Okay. So then is it possible, and just, coming off of that, Peter, is it possible then to have NHIF operate in such a way that you would not have to augment it by taking a private cover?
Yes, indeed. And in our contracts right now with the providers, we have 2 contracts. One contract is called comprehensive contract. The other one is non-comprehensive. In the comprehensive contract, the agreement with those facilities is that our members walk in and walk out without paying a single shilling. Okay? And they've agreed to all our tariffs, and they've agreed to all our package rates. And this is something that we'll make public. For the non-comprehensive, so that would be the higher-end hospitals, we still do our basic, the rebates, etc., and certain specialized services, which are covered. But for anything extra, then whoever chooses to go there would have to top up. So that way, we are able to handle everyone across the board and be able to contain the costs while maintaining quality.
Let's take a break. It's 28 minutes to 8, Kenya's biggest conversation. We have with us in the studio the CEO of the NHIF, Dr. Peter Kamunyo. We are talking about the radical changes that are coming to the NHIF. There's a bill before the Senate now, and it proposes several things that Dr. Kamunyo tells us are good things, and we want to understand good how. And what does it mean to my pockets as a Kenyan? This is a conversation that we're having. If you've got any question, please just post it on our social media, SpiceFM KEU on Facebook or on Twitter, and we will ask Dr. Kamunyo to respond to them. In the room is Eric Latif, Ndu Oko, CT Muga, and Dr. Peter Kamunyo, the CEO of the NHIF. The National Health Insurance Amendment Bill 2021 is now before the Senate. It is radical, Doc. One of the things that it's proposing is that if you're employed, you make a contribution to NHIF, and your employer matches your contribution to NHIF. Now, of course, this raises very many questions. Those who are employed and have a medical cover, does it mean that the employer now will be paying for you twice? One into NHIF and another one for this other cover by the office. And then where does that leave the other insurance industry? It appears like you're encroaching into their turf.
We are on a journey towards universal health coverage. And NHIF is a social health insurer. Currently, NHIF and everything that we pay draws 100% of its contributions from you and I. So it's either a voluntary contributor or my salary that is cut and contributes. So actually NHIF does not get any funding from anywhere. And we're going to social insurance. If you look at other countries that have been able to achieve UHC, the funding is vast, from self-funding and a lot of tax funding. And let's pick an example like Rwanda, for example. The employer contribution is 0.5% of gross salary. Then there's a whole raft, I think about 15 line items, which include, research money, fines, taxes on so many things to be able to fund their community-based health insurance. And it is fairly successful, though even our benefits, I think, are a little bit higher. But if we look at here, even with the employer deductions, the statutory deductions, you'd be surprised to know that 13% of the contributors contribute actually less than 500 shillings, which is even less than what the mamamboga out there, who doesn't know if she'll make a shilling or not per day. And actually 61% of the contributors is less than 1,000 shillings. So if we are really looking at going to get to universal health coverage, then we need to look at creating that sustainable model. And having the employers put their skin in the game is one that happens. Now without doing that, and you mentioned that now the ones paying for medical insurance will stop. In our conversation earlier, we're looking at, by the time you're paying for private medical insurance, it's because you want some extra benefits and extra perks. And that you'll be able to get. The number of people that we are talking about, privately insured, includes both employed and not employed, is about 2% of the population. In fact, in the last IRA report, shows about 2 million lives covered. If you talk about families, we're talking about just close to about 400,000 thereabout families. Whereas, when we talk about social health insurance, we're talking about, 50 million? In fact, currently our membership at NHIF as principal members is about 13.8 million, though only less than half are actually active. So we're talking about 5-6 million who are active at the moment.
Active contributors to NHIF.
Principal members.
Okay.
And now you're comparing to 400,000. So if you look at the bigger picture and the direction that His Excellency the President is also taking us to ensure that we have UHC, we have to look at how do we ensure we create the sustainability. And also please note, even under the Employment Act, it is a responsibility of the employer to ensure that they have that but they have medical cover for their members. Now, if you look at those numbers, then it means majority actually do not.
Let me ask this question.
Yes.
If, say, for instance, I am employed
Yes.
and my employer contributes to NHIF,
Yes.
am I allowed to also have my own private NHIF cover in addition to the one my employer has given me?
As an individual, we actually, you have your unique identifier. So there's no need of paying double because you won't get the double benefit.
Why not?
Because the benefit is per person.
Yes.
Yeah, and in fact, it's called something called like double insurance. Yes, which I saw somebody raising the other day, if husband and wife. But in that way, they're two individual beneficiaries, and their dependents can access the benefit. But you cannot have a double insurance. Even with private insurance, if you have two insurances, you'd have to consume one, then you consume the other. Or if there are two insurances, they might agree that, okay, then they will do a share, of the risk. So you cannot enjoy a double. If, let's say, you're going to have a payout, you won't get paid twice.
So, so
From the same insurer.
But based on what you've said, Doc,
Yes.
if you have spouses and they are both employed, they both have the cover.
Yeah.
And the assumption is that their
Yes.
dependents are covered with them.
Yes.
So spouse has the cover by virtue of the fact that they're working.
Yes.
Husband, wife, 3 children.
Yes.
On the other side, wife also has a job.
Yes.
She's covered.
Yes.
Her husband is
Yes.
covered by virtue of the fact that she is working, and then their children.
Yes.
What does that mean? It's still just one cover?
No, that will be those are 2 separate covers. Yes.
Okay.
So they will be able to have augmented, but they will not be able to pay for the same thing twice.
So,
So-
if one person gets sick, for example,
Yes.
wife gets sick,
Yes.
she's got her cover by virtue of the fact that she's working,
Yes.
and she needs a little bit more to cover for this particular illness.
Yes.
She cannot draw on this second cover
She can. Let
that
me
comes
give
from
a,
her husband.
She can. Let me
Okay.
give a practical example. Let's say their benefit limit was 50,000, and got sick, and unfortunately the bill came to 70,000. Yeah. So if it came to 70,000, one cover, her cover, would be exhausted. Then one on top, then you can draw from the husband's cover.
Okay.
Yeah. So it can work like that.
Okay.
But however, if her benefit is 50,000, and let's say the bill was 40,000. You can now say that, let me take
20 from here, 20 from here.
from there, because that is a benefit. Or if one has a reimbursement, let me get reimbursed on this one here while this one has paid for it. Now that one would not happen.
Okay.
Yeah.
All right.
I have a question here. Someone online has just called and they wanted to ask you a specific question. Let's hear from the Gitai Kanyeki. Is a police officer from Nairobi. Good morning, Gitai.
Good morning. How are you, brothers and one sister?
Good morning.
Good morning.
Good morning, brother. How are you?
How are you, Wanaomuga, my mwalimu?
I'm very well, thank you, Afande. And how is life?
For life is well. So now let me go straight to my question.
Yes.
Actually, mine is a complaint. Since 23rd, my wife actually on 23rd September, one of the hospitals in Nakuru declared her as dead. So when the system went to NHIF, the system saw that she's dead, so she has never gotten any treatment. I've been trying to call Nakuru, Nairobi, NHIF, nobody is helping. And even yesterday I was trying to call. Their lines are so busy. I'm asking the customer care to give me a specific person in Nairobi. They say they don't want to give me numbers. In Nakuru, I was told they actually misplaced a letter from that hospital, which they were supposed, even today, my wife is supposed to get treatment on, she has a problem on the eye, but she cannot access. So my question is, am I able to talk to Mr. Kamunyo direct? He gives me number, I just send him through WhatsApp the letter sent to NHIF Nakuru, so that action can be taken. Since 23rd September to date, my wife has never gotten any treatment because she's deemed to be dead.
Who declared her dead again? The hospital.
The hospital. I have the letter here. Even they wrote to me. They actually even sort of apology. They wrote a letter to Nakuru branch. And up to date, my wife, even yesterday, my wife also wanted to go to one of the hospitals in Medihill because of the eye problem. She cannot access because she's dead. According to the system in NHIF, where a mistake was done by one of the hospitals. But now, how to get Nakuru people, wanakuzungusha pande hii na pande hii.
You know,
Nairobi,
Dugu,
nobody can
you've
pick.
asked the right question at the right time because the CEO is here and he's going to respond to your
Yes.
question.
Yeah. So let him give me his number.
Wacha tusikie, wacha
Wacha
kupatie
kuelezea
mawaidha.
kwanza.
Yes,
Dr. Kamunyo.
Yes. Bwana Gitahi, how are you?
I'm very fine, thank you.
Good. I think the first thing is that you were informed about that occurrence by the hospital.
No, it was actually, she had been gone to various hospitals, but at one of the points, I think the second time he went to Nakuru branch, she went to Nakuru branch, sorry. That is when one of the staffs called that hospital and wakamwambia, nyinyi mnatuma mtu amekufa hapa. So she was actually even traumatized.
All right, so Bwanagitahi, I think you will send the details over and we'll have a look at that. But meanwhile, this is something that actually can occur. And a lot of the times it's because of fraud. When we have impersonation, and actually have quite a number of cases that have happened this year. So somebody uses your card or your number, goes to hospital, and then unfortunately, they pass on. So when that happens, the system will
Already
register as a
registers that
person.
you-
So I would really like to have the details, Bwanagitahi, so that we can
Yes.
investigate. In fact, of the 19 active cases we have right now on medical fraud, a number of them are because of such occurrences. And sometimes this happens without the knowledge of the principal member. So we have fraudsters out there colluding with also sometimes the hospitals, and accessing services. And this is one of the biggest challenges that we have had that we are looking at digitization being able to eliminate. But Bwanagitahi, Pole, about that, please
What we'll
ensure
do-
you send your details, and we shall definitely look at that.
What
And
we'll do,
Where do I
Gitahi,
send-
is
where-
we have
where
your
do I
number,
send-
so we'll pass on your number to NHIF, and our producer John will then get in touch with you after the show and see
Thank you.
once Dr. Kamunyo tells us how you can get helped.
Doc, even as we look at that, I think that's a really pertinent, and at the risk of comparing between then public and private, with like private insurance, once you access your insurance, the principal member gets a message in terms of, this has been docked. When you go to hospital or you're getting treatment or you're admitted, whatever, 25,000 has been used of your cover.
Yes.
So then you're aware if somebody else would have been using your card. Is this now part of this digitization that you're talking about, to have some of these things then regularized in that manner?
Indeed. And in fact, right now we're encouraging all our members to have their phone numbers registered. Right now, and with that number, if your card is used, you'd get a notification. If you go, one of the biggest complaints that we've been having is the authorizations taking long. So right now, as soon as your pre-authorization is lodged, you actually get to know. And when we approve, you get to know. So it is, we are highly encouraging everyone. As we do the biometric registration, we also ensure that our telephone numbers are registered so that you can be having that real-time alerts on your utilization and interaction with NHIF.
Beatrice in Mombasa also has a question. Good morning, Beatrice.
Morning, how are you?
Fine, thank you.
Okay, mine is just to ask the CEO. We have, the government have given out money to the old people, and you get that you realize most of the old people are not registered in NHIF. I have a case which I was called by one of my neighbor in a shamba in Kilifi, and they were telling me that I assist them with money to take the parent to the hospital because they don't have money. And I asked them if they are registered in NHIF. They say no. I asked them if they receive the money from the old age government project. They say yes. So I'm asking the CEO, why can't you work with the ministry and see if these old people can be be covered? At least even 500 can be removed, because it's not fair. You get somebody like her, the lady I was called, she's almost like 80 years, and they don't even have an NHIF. And the government have refused to take her because she doesn't have money. So
Thank
I
you.
don't know what the planning for the old people. I don't know.
Let's hear from the doc.
Yeah. But thank you very much for that suggestion. And that is indeed the spirit of UHC, whereby everyone actually contributes, and especially the sponsored programs. And the government has been running the sponsored programs for quite a long time now. And the groups of people who have been sponsored include the elderly, severely disabled, orphaned and vulnerable children. That's under the health insurance subsidy program. So also ensuring that they're registered under social protection would help. And these are all the schemes that we're looking forward to consolidating and having all of them in the 5.1 million supported. And this also includes like Linda Mama. I think I should have mentioned one of the big benefits that we've had over the years
maternity one.
is the maternity one, Linda Mama. And the beauty of Linda Mama is to ensure that all our women actually have supervised delivery, whether they are members of NHIF or not. And on average, we are actually helping about 1 million women every year, which is actually one of the greatest achievements during the tenure of His Excellency. And this is something that we want to continue. But this will be rolled in together as we sponsor the indigents.
Off the back of what Beatrice is asking, are you saying that the people who are in the Inua Jamii program, the 70% and above, who are registered in that program, also have automatic access to NHIF?
No, they
Or what do they need to do?
No, they also need to be registered under the HISP program so that
So there's
they
a separate program.
so that their premiums can be paid. Remember what I said? NHIF is a national health insurance, so a premium has to be paid for you to become
By somebody.
by somebody to become active, either yourself or your sponsor. Yeah,
The question she asked was, is it possible for the government to deduct it directly?
I think it's a good idea, and I think that is one conversation that we'll have with the ministry. As well as with social protection. And it's not something that is far from the thought process right now.
Because once that money gets into the hands of the people receiving it, for it to come out again,
Yeah, I mean, it's
That's why obligation for those who can afford is very key. And you can see that even from people with need, it's not prioritized.
among many other complaints that come in on NHIF is you're seeking health services, and then there's somebody somewhere in an NHIF office who sits and decides how much benefit you're going to get.
Yeah.
And it's not clear what they're using as a benchmark. You actually don't know. Somebody has posted on Twitter and says, I work in the private sector. Unfortunately, whenever I go to seek medical services, I'm told NHIF can only cater for bed only if I'm admitted. Even on admission, it's a small percentage. What's the point of having NHIF? Is complaining.
Those are two questions.
Yep.
Number one, in our new benefit structure, we have standardized reimbursement across the board, depending on the CAF level. So hospitals that are level 3s, the reimbursement rate for services will be the same. Level 4, level 5, level 6, the same, whether private or public. So that will cure that challenge that has been there. So this is one of the key reforms that we've done. And right now we're in the new contracting cycle of 2021-2024, and we're going into it.
so doc,
Yes,
somebody can just choose the hospital they want to go to.
they can choose. Now,
There's
number
no
two,
limit as to which hospital you can go to.
for inpatient is absolutely any hospital on our panel. For inpatient, you can go,
So long as in the
Has to
panel.
be in
so
the
long
panel.
as it's on the panel. Yes.
Okay.
And on the panel, how many do we have right now? 7,666. The second question was on the bed only, etc. Remember what I said earlier. We have two contracts. That's the two contracts we'll have: comprehensive contract and non-comprehensive contract. In the non-comprehensive contract, the basics will still be covered. You will have a rebate
Rebate on bed.
if you go, and certain specialized services if they've been contracted. So that will be it. But on the comprehensive hospitals, it is a full suit.
So how do I know which is which?
Yes, we as soon as we're done now with this contracting cycle, right now you can still get that from our service centers, but we'll also post this on the website because now this will be new contracts running from now until 2024, and they will be simpler and clearer.
As we conclude the conversation, I want to give you a moment to speak to Kenyans
Yes.
about Cell NHIF and tell me why I ought to, when my daughter gets to 18, tell her, Jilipia NHIF.
Yes.
But there's a question here. Do you have an anonymous platform for reporting fraud?
We do have. Actually, that's one of the strategic intents that we're having right now. But right now, from our toll-free number, you can actually call, and it is fairly anonymized because we've been getting a lot of the fraud we're investigating right now has actually reported through our toll-free line, and also through emails. And yes, we do have an email that is anonymized because it goes directly to the key personnel who are concerned. And this we can be able to share. The toll-free number is 0800 720 601. And then fraud at nhif.or.ke.
Okay.
Yes.
So you've eaten your time now for giving that message. In 15 seconds.
Yes. NHIF is there for you and has been there for you. Nobody can be able to carry the risk of unexpected financial spend when you get sick. The only way to protect yourself is to ensure that your membership is active at all times. And we will be there with you to ensure that no one is left behind and you are covered at all times with NHIF.
Dr. Peter Kamunyo, CEO NHIF, thank you very much for joining us today.
Asante.
Come back again soon.
I'm looking forward. Let's hope that when the bill passes, you'll invite me in.
Come, we celebrate. Yes, indeed.
This is the Situation Room, the only way to start your day.